Everybody got one?
Everybody got one? I won't be patient. All right. So, as Ms. Baca said, my name is Ashanti. I was a graduate here in 2011. I'm doing my bachelor's right now at LWIT while I go to my work every day. So you can do it. I take 2 classes most of the time. So it's pretty manageable. The online aspect is really great for me. Today, as she said, we're going to go over a lecture for the next hour before she jumps in. So, does everybody have a handout first? Have the slides? All right. So, we're going to talk today about what I think is probably the most important part of your job as a clinical hygienist, or as your future job as clinical hygienist. But I wanted to talk about first, or get an idea of what you guys thought were the most important things that a clinical hygienist does. Education. Yeah, that's very good. Education. All right, what else? Oral cancer screenings. Yep, shout them out. Okay. Motivation is good. Spelling is awesome. What's that?
Oh no, you have some mops up there.
Mopping, yes, you've got to clean the office. Any others? Treating the disease, that means scaling. Treating, out, look at this people. Treating the disease. And what else did I hear? Did I hear one more?
Restorative.
Restorative. Good. Would anybody want to be a restorative hygienist? Yeah, we got a lot. Good. Well, I will say good luck. I wish you luck. All right. So these are all great things, very important things as a hygienist. Steady. Okay. So all great things. I really want to focus on this one today, preventing disease. We'll talk about how to recognize it's going to be treated. So we'll primarily today talk about periodontal disease. I want to let you know that most of the patients, or almost half of the patients that you'll see out in practice do have periodontal disease. 47.2%, according to the CDC, have periodontal disease. We also see that 70% of adults over 65 have periodontal disease. This is incredibly important, as we know. You guys probably see a lot of seniors down in the clinic right now as your patients. Certainly the baby boomers, many of your parents are well into their 60s by now. And then certainly grandparents will be coming in. So that's a huge segment of the population in the country today. So definitely be prepared to see a lot of seniors, be prepared to see a lot of periodontal disease. As a clinical hygienist, we want to be able to recognize the disease so that we can treat it. I mean, that's really the first step, and some of you guys called that out already. So I'll get to my title page. If I can move you away a little bit, identifying periodontal disease through periodontal chart interpretation. So quite a bit there, but it'll be a little easier than anything. So we go on. Next, I want to show you a series of images. You'll see them in the slides, but maybe not out of glory. Look at color up here. These should be slam dunk. This is perio. As soon as this person walks in the chair and opens their mouth, you see this, Mr. X, Miss X, you have periodontal disease. Okay. So let's go ahead and take a peek at some of these images. All right. So this one. So we've got tons of recession here. We know that there's bone loss underlying here. We've got the bleeding just by looking at it. We've got just like that's all it takes. So we have, if you look closely, you can see that this person's lost quite a few teeth. There's a partial here, the lower anterior, off to the right side. There's a partial. So their periodontal disease is pretty severe. As we move on, this is a patient that's more stable, right? We don't see all the bleeding, but the gums look pretty healthy. But certainly, there's been considerable loss. There's quite a bit of recession here. 3 or 4 millimeters, I would say generalizing. So a more stable patient, not the cleanest mouth, but certainly a slam dunk. This is perio. They're only your perio patients. So here again, incredible swelling here, edema, lots of recession, bone loss here, down the interiors, same sort of thing. They look happy, but this mouth is in bad shape, so don't let the big smile fool you. Again, I could just go on and on. I know you guys are eating cupcakes, so I should probably get through this, but again, they sit in the chair, they've got the just looking at it. So now we'll move on to some other images. Again, that will be a little easier on the stomach, but you should recognize these as periodontally involved. You take your film, you see these. This patient has perio. So let's look at some of these. Significant bone loss here. We can see the furcation here. Looks like it's plastic for sure. Yeah, right here between 31 and 30, certainly. So.
What's going on between 30 and 29? Is that where the bone loss is?
Probably, it looks like at least a bony defect there. That would be scary.
Wait, is that real? I read that somewhere.
Hear about the ghost teeth?
Maybe it was in my dream.
No,
I really feel like that.
No, we talked about it.
It was
You guys know stuff I don't know. Alright, let's take a look at this next picture. So this probably isn't the most over the top. Oh, thank you. This isn't the most over the top perio case, but certainly they've got bone loss. If you know where the margin is, you know where the bone should be. We can see that. That there is some bone loss here, and there's enough that this person has periodontal disease. We go on to another film. It's kind of a grainy picture, but looks like 29 is missing. There's significant loss here between 30 and 29. There's probably a class 4 furcation here on number 30. Again, we see the loss here. So especially 12, 13. Again, it's just significant loss. You take this pan out, this person. You've got to go and tell that person that they have periodontal. And again here, likely a furcation there, certain bone loss. So those are, I think those are things. Even as a young student, you recognize those right away. The next images are ones that are really equally as telling, but they might not be so obvious for where you guys are right now. But it's certainly important. And those are the periodontal chart. So if you look at this chart, I know that the slides you have are black and white, but if you can make out the numbers, you can make out the numbers in color here. We've got our deeper pockets here in red, 4s, 5s, 6s, there's 8s here. We've got some 7s around the chart. So lots of red for this patient. I know that some of these red numbers are 2s and 3s, but if you really look at the numbers themselves, there's really quite a bit of loss there. Pretty deep pockets here. We'll move on. This is some software. Is this EagleSoft? You guys recognize this? No, it's not Dentrix. That's what I use. Those are probably the most prevalent, the most common software that you'll see is Dentrix and EagleSoft. This is some other one, but it gets the job done. Lets us know that this person, lots of 4s and 5s. We'll see some 6s down on the lower arch. So again, we're talking about periodontal disease. On this slide here, again we see 6s and 7s, 5, 6, 7s here in the posterior. If you look closely, I'm up here in the upper right here, you can see furcations here and all the molars, furcations here as well. Furcations here as well. So again, deep pockets is just a snapshot of a larger chart, but the idea is the same. We've got also recession here, so definitely this patient has periodontal disease. They need to be treated as such. So, but ultimately, I want, by the end of the day, I I want you to be able to recognize this for what it is. I want, when you go to the clinic, when you're doing your chart reviews in the morning, and there's a reason, is to see things like this, is to find these patterns, is to make sense of the matrix that these can fill out when you just get started. So that's most of it. I've got a tool for that. So the periodontal chart is full of useful information that helps us differentiate between a patient that is clinically healthy or may just have gingivitis. What we may think when this person comes to this thing, right? And helps us differentiate between this and a patient with unstable active periodontal disease. And as I blow that first picture up, we can see now we've got an pocket there. We've got some heat. They got the effects. You see the bleeding in the sulcus. Lots of edema here. Edema that is here, but it's not maybe so obvious. Again, we'll go back a few slides to this picture. This person sits down. You just see this. There's no recession. They look like they do a decent job, at least of cleaning their teeth. This can be misleading, but it certainly doesn't say that this person doesn't have periodontal disease. So definitely the period charting is important to that end. So when we do our period charts, we're looking for four things primarily. There are other things, mobility, that I won't get into, but first we talked about pocket depth, right? So we take our measurements. We've got good angulation. I'm working with first years right now, so they're super awkward. But so we're looking at we know that pockets are a place that bacteria fill in, right? Bacteria fills the pockets. It destroys the periodontium. I had trouble writing this sentence just because, on a high level, it's true. It's what you would tell your patients, that bacteria in pockets leads to bone loss, it leads to gum loss. But I think, have you guys taken both perio classes already? Yeah. So it's really, more of it is the body response to bacteria, right? That kills the tissue. But, not every patient wants to hear that or would understand it or whatever. So at a high level, bacteria in pockets is pretty bad stuff. We know that the deeper the pocket, the more area there is to clean. Typically areas that patients can't reach. Sometimes for us, it's areas that's very difficult for a clinician to reach. Sometimes people need to work with periodontists in certain situations. But these are the type of things that you do want to explain to your patients. You do want to explain. Tell them that they have periodontal disease in the case of pockets. Why is this pocket impacted to you? How does it make it difficult for you to maintain a high level of health? So, it also gives us our roadmap. It tells us where plaque and calculus are sure to be found. We're going to measure it from from the margin to the base of the pocket. As we move on, we talk about recession. Recession shows us the loss of healthy tissue. We certainly can see in the picture, healthy area or near recession. We can see perforation here. We want to prevent further loss. We want to continue to protect the roots of the teeth with tissue. Certainly, recession leads to sensitivity, right? It leads to root decay. When in a situation of perforation, certainly if there is everywhere to be decay down in the perforation, that tooth is lost. That's not a restorable area. So lots of reason to encourage the patient, as someone mentioned over here, encourage and motivate the patient to maintain the level of gum and bone that they have. And then just as an aside, we measure this from the CEJ down to the gingival margin. We move next to clinical attachment loss, which I called critical attachment loss for quite a while. Beside the point. So clinical attachment loss is a representation in millimeters of the amount of periodontal ligament fibers that have been lost. So, we look at this as the amount of exposed root surface in a given area. I certainly want to express that by exposed, I do mean accessible to bacteria, accessible to a probe. So both above and below the gum line. It's all the area that the patient will need to clean keep the tooth, to keep the pocket clean. So that's what I mean by exposed, not just what you can see clinically. Certainly. And so this measures from the CEJ to the base of the pocket, or in other words, the pocket depth plus recession equals cow. Most of the software, Dentrix, Eagle software will calculate this for you once you add pocket, insert a pocket depth, insert a recession reading, but on paper, there's a paper charts out there, so and that's kind of how that works. So we go back to bifurcations. Again, these are more places for bacteria to hide. They're particularly frustrating for patients. I mean, it's very difficult. If at all, it's difficult for them to clean these areas. We certainly can encourage them to use things like perioids. In the case of class 4 application, we can also encourage the use of a proxy brush to go through that area. But they're pretty difficult. They even can be challenging for a clinician. Sometimes, depending on the severity, these are, the patients with the class 3s and class 4s, sometimes they're encouraged, if they're not showing progress, to go see a periodontist. So again, as I mentioned earlier, you have decay in the bifurcation, the tooth is essentially lost. Okay, so now it's time to make sense of all this information. Again, I talked about, seeing through the matrix, if you guys are open up for that movie. We need to know where to clean subgenitally. The periodontal chart creates that map for us. So very important for what we want to do, and again, what we want to do is help the patient. We want to let them know how they can impact their own health. Again, in the case of pocketing, where they might want to use a perioid. So I've certainly had situations where I've sent a patient home with their periodontal chart. I might have highlighted some certain areas, like these are where the deepest pockets are for you. This is where you use your perioid. This is maybe where you would use a monojet syringes for hexidine for a couple of weeks. So there's different management strategies. So don't be afraid to pass this up on to your patients so that they can really take charge of their health. Me and Ms. Baca saw things the same way. We talked about how even if a patient comes in 4 times a year, right? There's still 360 days if they don't come in. So it's really about how do we empower the patients to take back their health. As it says here, the period chart also is useful in determining AAP classification and therefore the type of cleaning that a patient requires. So this is a quick overview of the different cleaning types. We have the prophylaxis for sure, and then there's scaling and root planing with subsequent periodontal maintenance cleaning. And the period chart also helps us to determine the root cause frequency so that optimal health is maintained. So, are you fine coming in at 6 months? Are you showing that you're not actively losing tissue? Do you need to come in 4 months? Every 4 months? Do you need to come in every 3 months? This is the period chart definitely helps us to figure that out. Again, typically not so much with regard to recession, but certainly with pocket depth, with rotation. These are the things that are most challenging for patients to clean, and so we need to pay special attention to those things in particular when we come up with their root cause frequency. So without going to AAP classifications, every patient you see, you figure out the AAP classification. And I think you guys do that now, right? So that's nothing new. It really takes over as you start working clinically or in the private practice setting. It really takes over as the most important thing, as opposed to I think what is probably most important to you guys now. It was certainly important for me, and that was your calculus. Okay, I have never, not once. I work full time. I've been working at my office for 2 years. But I've also spent some time temping, so I've been in a ton of offices. I have never once written down someone's calculus code, so we definitely need to know the AAP. We need to know why it's important. Again, it helps us define calculus. It helps us to know where my height, but it's about the AAP. So And it's subject to change too, so, you know, you can let patients know that as well, and it's something to know for yourself. You know, certainly, again, you know, when a patient just has deep pockets, you know, some patients, you know, will go from, for example, AAP4 to an AAP3 as their pocket depths improve. It's pretty rare. I mean, I struggle to think of times when I move somebody back in that direction, but certainly patients go the other way, right? If they have risk factors, smoking, diabetes, for home care, they certainly can go the other way to go from a 2 to a 3 to 3 to a 4 and beyond. So we need to let them know that once we've done the scaling and replaying, the game's not over. We got to keep fighting the fight. So we'll move on. I think this is very important, and this is one of the challenges as a hygienist. Is the reason why I'm here today doing this particular question, and that is so for a patient with insurance, the insurance company will determine how many cleanings the patient is covered for you. So whether it's at no cost to the patient out of pocket, or whether it's a little cost to the patient out of pocket, they'll make this determination based on the AAP you give. So it's important that you give an accurate one. It's important. It's you know, I also see in practice, I guess, that AAP3 is usually like the line of demarcation for when a insurance company will give you more cleanings. So a lot of times we'll see if you have AAP1 or 2 and you're getting quad skills, usually not going to have to feel one. But if you're AAP2, they'll give you, let's say, 2 cleanings a year. And then once you get AAP3, a lot of companies will open you up to 2 more cleanings a year. So now you can have 4 cleanings a year. It's very easy for the patient to be compliant if they have little to no cost out of pocket to come in every 3 months or every 4 months. You certainly have that struggle. Yes.
Increase their number of cleanings without doing something.
You asking you or you telling me?
I'm asking.
You're asking me? No. We'll get to that because that's an important point too. So no, you can't do it without this. I think I was saying that you might get now 4 cleanings a year, so it gets easier for the person to take care of their health. But whatever the situation is, whether they don't get the extra 2, whether they're a cash patient, the recommendation is a recommendation. Okay, if they need to come in every 3 months to maintain their health, and you tell them you got to come in every 3 months, or we see things go the wrong way. If they need to come in every 4 months, same thing. So sometimes you'll be made aware of what a person's plan is if they have a plan, but you never let it dictate what you recommend. You know, whether the person comes in every 3 months like you suggest, or they come in every year, you know, that's up to them to decide, right? You give me your recommendation as a professional, and maybe it's an ego thing or whatever, but I feel like people respond when you say my professional opinion, because once you leave here and start working, you're a professional, right? So take advantage and stand up for what you believe in that regard for your patient's health. So now, you know, we'll get into the AAP classification. I'm going to go pretty quickly through the first couple. They're really outside of the general scope of what we're talking about today. So AAP 0, you know, clinically healthy. These are maybe mostly finest in adolescents. You kind of really see these patients.
Well, that's only an adolescent with a clean mouth.
Yes. So not the
grunge mouth.
I used to check. So let's see here. So AAP1, chronic gingivitis. So we need here probably 1, some 2s, maybe some 3s added into it. Chronic gingivitis, characterized by the presence of inflammation confined to the gingiva and associated with teeth showing no attachment loss. You probably have this written verbatim on one of your handouts for the ticket from stuff that I say. So now we go into class 2. I've got some bold text here. I've got some bold text down here. These are the things that you can find in the periodontal chart, I did not bold, slight crest of radiographic bone loss. It's important. We use all the tools that we have available, the perio chart, the film, we use the clinical exam when we're making this determination, but again, it's outside of the scope of what we're doing today. So here we're going to talk about the cap. We've got the 5 millimeters cap. We've got the generalized 4 millimeter probing depth with some isolated 5 millimeter pockets. Is everybody familiar with the term isolated? Yes. Yeah. Okay. Good. I was worried. I was in the clinic and it's generalized and localized, and I thought there's still this other component out there. Everybody's familiar with it. We move right along. AAP3, so we've got some more significant cow. 6 to 7 millimeters. We've got generally 4 to 5 millimeters with some localized 6 to 7 millimeter pockets. You might have rotations. The way we learned it in school is if somebody has rotations, then they're at 3. Okay? Is that still pretty consistent for you guys?
What's isolated? I feel like now I don't know.
So cute.
Is it the same thing as localized or no?
It's not the same thing as localized. So you're right. It's really just a single spot. So maybe it's the interproximal of a certain spot or a certain tooth that we're talking about, depending on what we're talking about. But yeah, it's just a single spot, and then we go from there up to 30% is localized, and then from there on generalized. Okay, so I think somewhere there's a slide about that. So it'll be written down if you didn't catch it. But yeah, that's what we're gonna do. Good question. Let's see, AAP4. So again, this patient is in more trouble if they're unhealthy. We have 8 millimeters or greater of attachment loss. Probing depths are generally 6 millimeters and above. They usually in this case have rotations because of the significant attachment loss we also see here. We usually see more for root and exposed, so that tends to come with rotation. And then the AAP class 5 is the aggressive perio. There's rapid attachment loss, bone destruction, seen in an otherwise healthy person. There's usually a progression of the perio breakdown even after aggressive intervention. So I don't see this a lot, but I certainly see it. It can be very frustrating for the patient and challenging as a clinician. You feel like you've done everything you don't find harder. The person has maybe had hormone care, or they smoked, or they had uncontrolled diabetes or something, but now they've made the change. They control their diabetes, that's the thing, they stop smoking. Well, home care is great. We've got sonic care, they use it on the floss, and when they come in, their teeth, look immaculate. A few millimeters below the gum line, you don't find plaque, but you get to the base of the pocket, it's deeper than it was before, it's still bleeding. So, I think it's, I said for the patient, I think it's frustrating for me too. So, a lot of times, at this point, we feel like it's best if they're seen by a periodontist who may have some surgical intervention and may get them on the right track. So yeah, again, you don't see it a ton, but it's certainly good. Okay, so now I'm going to jump back to the computer. I'm going to show you guys a periodontal chart of a patient with this pseudonym. So this is Ann Sizer here, and I didn't come up with that. And
It's actually pretty cute.
well, see, my other one's Perio Brett.
Oh.
Irish friends. So this is not what I want. Here we go. So here, this one. right, so I'm just looking, I'm looking for a couple of hands to help fill in the blanks in the period chart, just to kind of give our minds a little workout here. Does everybody see that okay? Is that reasonable for everybody? All right, so, looking up on number 2, does anybody want to take a shot at, yes? 6. Okay. What about number 14? All right, how many people say 8? Raise your show of hands. Yes, and 4. Who's got 4? And then others.
Wait, are you talking about the top one? The buckle side or the top?
Oh, okay. I'm sorry. On the buckle of number 14. 4. We're in agreement. Sweet. Okay. And then the lingual of 14. 5. Okay. What about the lingual of number 3? What would we expect in this section? 2. Right. So if we go back to number if we go to now number 24, right? We see that we have 6 millimeters of attachment loss. We've got a 3 millimeters of recession, right? So we use those things. We go cal minus recession will give us our probe depth, or cal minus probe depth will give us recession. Recession and probe depth will give us cal. Okay. Did everybody okay with that? Yeah. All right. So now we will go to okay. So I've got that chart filled in. I've got it color coded appropriately. So I'll go to that in just a second. What we want to do next is see again. I just isolated on. We want to go to so make that note for yourself. If you didn't know, isolated is really just a single site. It's less than so what we want to do, we'll open up Anne's chart again. We want to give her an A and B classification. We'll do it for each quad, and then we'll try to use that. We can use these rules, and we can give her an overall AAP. Because the next step, we need to figure out how we treat them. All right, so here's our chart filled out. So why don't this row work on the upper right, and you guys work on the upper left. So we'll figure out what their A classification is. Make it just go ahead and focus on the quad. We'll use the rules that we talked about: localized, isolated, generalized. And I can blow it up for you guys if you like. But will you make your conclusion, and we will judge these guys harshly when they give us their assessment.
don't have any.
In the lower quad? Yeah. In the lower arches? I'll scroll up and you guys can watch it. So, does the first row have an idea where they want to
I'm pretty leaning on 4.
AP3, okay, why 8?
Because we have cal of around 7 millimeters, and the pockets in that area are kind of generalized 4 to 6, with some 7. And recession, there's no rotation flow, and there are 2 deeper pockets, the D and the AA2.
Okay. Does anybody have a challenge for that, or?
What are you guys
Sorry, we're looking at the upper right.
Okay.
Right, upper right. We're looking at the upper right. Does anybody have a challenge for AP3?
Oh, here,
Yeah, you raised your hand on that.
are you challenging it?
Like, no, I think it's a 3.
That was in agreement.
I thought you were saying who was 4. I was.
What do you got?
It's an AMP3 based upon this, but it seems like she's leaning towards a 4. Because if you do WAG, you know, her width of attachment loss on like the linguals is like 0. Not cal WAG.
Do you do wag on the lingual soy?
Well, no, I'm just saying like if you look at like, okay, so number 2 would be a 0.
You can't calculate it.
I thought you were saying 4. Oh, because we don't have that. I'm sorry.
Have another
I
cupcake.
have too many cupcakes.
Soy, I think you need some more sugar. Have another cupcake.
Well, for none of those reasons, I think you're right. I think that she's okay.
We have that.
All right, so we're looking at generalized. We've got more than 30% of the sites have 6 millimeter pockets. Okay. So if you just think about generalized as what they have the most of, I would say she doesn't have mostly 6s. But we want to treat the extent of their disease. I see her as a 4. Again, she's got more than 30% of the sites have 6 millimeters. Yes.
Actually,
Ashanti, are you sure you want to teach? They do this every time. I know.
and it's on your
What's that?
You're going on Cal. He said you're going on Cal.
What's that?
You said you're going on Cal, correct? Clinical attachment loss.
Yeah, she's got the 6s there and the pocket depths for sure. What's the? Okay. You know what? I'll explain this, but let's knock this quad out so I can show the bottom arch. Let's get back to that. Yes. You said 3 also. All right. So I heard this get brought up a few times with the furcations, right? They have not written in the furcations.
And that's always tough to admit, isn't it?
Yes. So that's my bad. This we said that AP3, or if we have furcations, they're going to be at 3 of these, right? We're talking about that. If there's not furcations, it doesn't mean that they're not. But I clearly have realized now that I have not drawn in furcations. So I will let them. But yes, I think yes, she was in AP3 in the upper. Okay. Why don't we quickly 2 minutes we'll look at the lower quads. You guys can shout out where you think she's at. Did I hear 4 on the lower left? Good, good, good.
There's not, but there's generalized.
That is 3. I have a quick question while we're thinking about
Sure.
when we do the classification, if 3 quads, they're a 3, and we think in 1 quad they're a 4, their classification will still be a 3 though, right? Because you can't do like 3/4.
Right, you do need to give them,
Just a standard.
you need to give them one thing.
And that's where the localized is generalized. All fine, it's actually the full mouth, not the quadrant. So she'd be a 3.
Right, now, you know, when I was in school, I think it wouldn't be localized. You know, let me get right
No,
back.
I mean like in private practice.
I got you. What, did we figure out 4s and 4s? Okay, so this is an AAP4 patient, even though, you know, if we want to say that they've got a 3 in the upper right. In private practice, when a person has a mixed quadrant, now certainly we need to know that this is not the total picture, okay? We think it's a huge part of the picture, that there's still some films to look at, right? There's some rotations that are uncharted, but we've got most of the picture here. Yes, you're gonna give them the, like here, you're gonna give them the 4. Your question was if they have 1 heavier quad, like 1 4 and then 3, and then 3 3s. You know, when I was in school, I think we would chart it as there are 3 here, and 4 here. You're always gonna treat them to the extent of their disease. So we can't forsake that 1 4 quad because we're trying to treat them as a 3 that they generally are. Okay.
Do you bill it out as a 4? The whole mouth as a 4?
You would usually build out as a 4. Is that what you see?
Well, it depends. One time when I was in private practice, I went in and because standard of care, right? Wanted to do 4 quads, and I didn't notice that the previous hygienist hadn't charted recession. And so I just sent it in, and I said, look, this is what we need to do, predetermination, because I knew what I was getting. And I went on the previous because it had just been done, and the insurance company comes back and says, nope, we're going to do a 4-3-4-2 because these, and the recession wasn't there, but she was generalized. So unfortunately, the patient went through with it. You know, I mean, either way, she was going to get it done. But it all depends on the people that you work for as well.
Yeah.
Because what we want to do, because we know it's right here, is not always what your doctor is going to go with. And ultimately, who has the last say? Unfortunately, yes.
And you know, take advantage also of a good narrative. I mean, if you
Yes.
just the way a doctor would write a narrative for a crown, you know, you need to write this patient as you see him. It does make a difference. I've certainly had things come back, and I've written a better narrative.
Because you learn
Still
on each
inaccurate,
mistake,
though.
right?
Right, exactly. And to them I did. And you know, and it comes back and gets turned around a lot of times. So that's good. You also, for your question, you guys know about the 4-3-4-1 and the 4-3-4-2. You know, you might do a 4-3-4-1 down here and here, not on this patient, but and then a 4-3-4-2 in another quadrant, right? Again, as when you see them for their maintenance, you're still worried about the heaviest quad to do right with the patient, but you certainly can mix the way that they're billed as far as how many sides are affected, or the extent of the effect. Let me go ahead and switch screens back, and we'll move on. So and that really brings us back to. So that brings us back to what type of patient the clinic needs. Does anybody think you need a prophy? No. Does anybody think you need periodontal maintenance? No. They don't. Scaling and root cleaning? Yes. The non-surgical initial treatment of choice for controlling periodontal disease. As I mentioned earlier, it's a way to start, but sometimes depending on the need, they may be referred either initially if they have very severe carry on and it really was losing teeth to a periodontist, or if things do not seem to be controlled over time, you might refer them. A lot of times you go 3 months there, 3 months review, 3 months there. And so forth and so on. We'll follow this with their pair maintenance, right? So now they come back in. I know you guys do your tissue checks at 6 weeks or whatever. They'll come back in, you'll get an idea of their home care, see if they start to make the appropriate changes, see how they healed in that time, and then we can figure out the recall that's going to get them to a stable state. Typically they're done at 3 or 4 months. Again, as I mentioned before, we've got smoking, diabetes, and poor home care as factors that certainly impact that.
What exactly would periodontist do different than what we do?
They certainly have the ability to do a gum reduction surgery.
So I mean, like going back, 2 months.
Oh, right. I don't know. I just think they got like a magic. I don't know. They have cameras for sure. I forgot what. Yeah. So yeah, but we see good things. So we send them over. So we figured that out. Okay. So here is now another tricky situation for you guys, and you'll see it. You'll see it often. Okay. New patient comes in. They've got generalized 3 millimeter recession. They've got clinical attachment loss. They've got let's say 30% of the bone missing in most places. So they're 3 or 4, but they don't have any bleeding. They don't have any target. They don't have any plaque. They have healthy 2 to 3 millimeter pockets. This was. So there you go. Period maintenance. How do we get them? Why a period maintenance? Okay, so you're saying that they're a stable patient with periodontal disease. Their pockets are healthy, right? Right? Yes.
Is this the first time this patient presents in your
Yes,
practice?
Yes. This, if I didn't say loud enough, this is a new patient for us. New patient for us. Does that change your mind at all? Yeah. All right. Okay, good. Right. So you can take advantage of the limited codes. This patient, it sucks that it has to be this way. That you have to go through the hoop of the scaling and root cleaning. But this patient does have periodontal disease. They have shown risk factors. Yes, Ms. Buchan.
One more question, because I know it comes up in private practice.
Yes.
Do you ask the patient if they've ever had 4 quads of NSPT?
Yes. Now you would hope that your front office has already gone through this when they made their initial call to the office. You certainly would hope that they've done their homework. There is most plans. There's an expiration date. So if you've had scaling or root planing, and then you've lapsed in your maintenance for 2 or 3 years, depending on the plan, you need to go through it again. If you were over here and you had scaling and root planing, and somebody decides you're so healthy you should get trophies, you usually disqualify yourself for future perio maintenance, and you've got to go through it again. So you do want to check. Maybe they've just moved, but they've been on time otherwise. So in that case, you could, as you said in the red, you could go right to the perio maintenance. But otherwise, if they don't have a recent history that stands up, so you will need to scale.
So you can transfer care from one clinic to another without,
If the patient, typically the patient has the same plan.
okay.
So it's not a matter of transferring care, it's knowing what they have paid for and what treatment they've received before. So that's what you're doing. You're not transferring care, you're aware of what their previous treatment was. Okay?
Insurance will cover it again, the initial care.
But the insurance will pick up on
Right, if they
PM.
They'll pick up on a PM.
lapsed, right.
Yeah.
So we said a new patient, what else you'll see, because the patients that you guys first see won't have been your patients for long, right? I mean, they will be new to you. They will have been seeing someone else. A lot of times you'll see, I think it's a lot of times seniors more than anything, they're perio patients, but they've been coming in every 6 months and they get their brokenness. And that's what they're used to, that's what they know. So it's a pain because they're really a perio patient. Now you need to put them through, I won't say put them through, you are helping them as you perform the scaling and then the subsequent perio maintenance. They've shown that risk, they exhibit the loss. So again, I think we've covered these points. These patients do have periodontal disease. They should receive maintenance cleaning. We talked about the insurance aspect of it. And that's true. Even when their disease is stated in the scenario is stabilized. This is as healthy as this patient is going to be. They're not going to regrow the bone. They're not going to regrow the bone. They're as healthy as they're going to be. We wanted to say that way. So this is okay. So in closing, as I've said before, it makes sense to use everything you have available to you: the film, the clinical exam, their health history, the dental history, and of course the perio chart for making decisions. But I think you can go a long way with the perio chart. It shows you so much. It shows you the difference. So if we go with the way back machines with some of these films, radiographs, we look at this person and we would say, that bone loss looks like you might have perio disease. What do their gums look like? Are they stable? Do they just have a scaling root thing and it's stable, but like we said, the bone's not going to come back. So are they stable, or are their gums falling apart and they need you to get you released? So that's what the perio chart helps us to figure out, that the radiographs can't show us is the healthy tissue, whether the person is actively losing tissue or whether they're stable state. And in closing further, we need to being able to recognize the patient is healthy and encouraging them to keep up the good work goes a long way. We talked about the word encouragement. Being able to recognize disease is the first step in getting a patient on the road to health. And the perio chart is a great tool we use to determine where that patient is on the health disease spectrum. And that is our presentation. Does anybody have any questions?
So what happens with those patients who have been billed out as pro-piece forever and you come to the practice and you're the new hygienist and then you see that they should be or SRP?
How much time do you have? They don't want to hear it a lot of times. I mean, they do. I mean, we get a lot of them too because it's as we go back to our first slide, education, right? We talked about we got to coach them up. We got to let them know why it's important for them. It's a challenge. It's fortunately not a daily challenge, but it comes up often enough that it's a challenge because you see this person making the effort, doing the right things. They probably have the scaling at some point. It's challenging, and to that end, they know that they needed the scaling for a reason, right? Because they've got periodontal disease. So it's really about education and letting them know the whys. Yes.
So if something is there they shouldn't have been, and you're coming to them and saying this is what you need, and they're like, I don't want that, I'm going to keep doing what I'm doing. You can't do that, right? Because it's compromising their care, even though they're declining what they really need.
Are you saying that I can't keep doing trophies because I'm ethical? Is that what you're saying I can't do?
Yeah.
This will be something that as hygienists you get to talk to your practices about, your doctors. My girlfriend's practice, they don't see it. If you come in as a new patient, you need the quads, you say no, you have to do it. Whereas other practices, they'll continue to see you, and So it's really, I understand your point. I think you're kind of leaning towards supervised neglect is, I think, where the point you're trying to make. It's the policy of the practice. Yes.
There's a third option. There's some doctors that will have the patient sign and say, this has been recommended to me, I decline. Okay? So that is a third option.
So that would be kind of like what we do at ProBraille, where it's do what you can.
No,
Provide the best care you can.
you would write, 4 quads has been recommended for this patient due to the periodontal status. However, patient has declined treatment at this time. And the patient signs off.
And just requests.
And then requests a prophy. Patient has been informed of the amount of bleeding. And then every time that patient comes in, they go through the same thing over and over. And then like he says, there are some practices that won't put up with it. It's like, okay, you don't want this, hit the road.
So if you are seeing a patient who's supposed to be an SRP or a PM, and they're being billed as a prophy, when, as a hygienist, when they're in your chair, do you pick up your scaling instruments, or you just do a basic prophy like an assistant? Or do you just still do the same amount of work? Just like, what's the policy in the office? Does your doctor expect you to still scale all of the teeth in 1 hour, or?
Gotcha.
You know what I mean?
Yes. So this was a challenge to me because in class or in school, you figure out who the patient is, you provide them the service that they need, right? Every piece is checked. It was so weird to leave something behind if a person needed the scaling and elected not to go forth with it. My practice now, and I don't particularly care for this, but we get a new patient in, they come in for new patient exam, films, prophy. They need quads, we still do the prophy the same day, and then bring them back and do the quads. Now we know that if a person needs quads, right, I don't do them a ton of favors to their health, right, maybe the appearance of the teeth, but to their health by just doing the prophy, right, what am I doing? So it's not the policy of every office. Again, like I said, when your office practice, they start them that day. If it's just 1 quad, then they do 1 quad. If it's whatever, they're not cheating the patient, or I loosely say cheating, but they're not doing a cleaning when we know we're not doing a cleaning. So it's a challenge. Yeah, you will often clean up the crowns of the teeth, maybe a few millimeters below, but you're not down to get on the target. So it's weird. It's definitely a shift in thinking and behavior.
Sometimes our do the like if they're coming back, if all of a sudden their teeth look clean. They might not be as motivated to come back for the SRP.
Right. So you guys, and we do this in practice too. We won't polish, for example, until the whole mouth is done, right? Because everybody, the polish is before. Yes, I think so. It has been a struggle and a battle with my practice to change that policy. I haven't won yet. But what was your question? Any more questions?
I think, so what is your doctor's reasoning for having you do the prophy? Did you answer that or explain that? Why do you do the prophy before they come back for the SRP?
What is it booked out at is it like a 2-hour-long appointment or something?
Their initial visit?
Yeah.
Oh yeah, in my practice we do an hour with the doctor and assistant to do the pills, intro photos, blood pressure, health history, exam, and then they come to me for period charts and then the program. We do education at that time as well. So